I start? Okay, so good morning, good afternoon, good evening, hello and welcome to the launch of an ILO publication titled Making Universal Social Protection a Reality for People Living with at Risk of and Affected by HIV. Kofi Amekuji is my name and I work with the ILO as an HIV specialist. I am privileged to be your moderator for today. We have 90 minutes to spend together, and how exactly do we hope to use this time and to maximize this time? We will first start with a presentation on the findings of this report, and the presentation will tease out all the critical elements we want to discuss today. And then from there, we will move straight into a panel discussion. I'll be introducing the panelists as we go on, and the panel discussion would give us an opportunity to learn from the very knowledgeable panelists who would also draw on their rich experience based on the findings of this report. The question and answer session, you would see right below your screen, you see a question and answer function. Kindly use that to ask any question you want. Please do not use the chat box. The Q&A function is for questions. And once we get your questions, we'll do our very best to respond to them as long as time permits before the program is over. The chat box can be used for anything else. If you have additional information you want to share with us regarding a link to some additional resources, kindly use the chat box. If you want to let us know who you are and the organization you work for, kindly use the chat box. So the chat box is for everything else, and the Q&A box is for questions and answers. If you wish, when we are done with everything, we will actually finally come to closing remarks, and I'll be introducing the colleagues who will be responsible for the closing remarks. The idea will be to dot all the I's and cross all the T's as we finalize this webinar. So without much ado, let me introduce and hand over to Afsa Mohammed, who is the lead of the HIV and AIDS unit in the ILO, to deliver some opening remarks and scene setting, as well as to introduce the presenter of the findings of this report. Over to you, Afsa.
Thank you very much, Kofi, and welcome colleagues into this webinar, in which we are launching this publication. As Kofi said, we will have a presentation on the panel, and then we'll have a very distinguished panel to discuss the report and its implications, and also share their perspectives. I'm extremely happy to join you and make a few remarks on why is this publication and today's discussion so important. First, public health challenges cannot be dealt with by health interventions alone. And this is the lesson we have learned in over 40 years of AIDS response. There is treatment available for HIV, and TB is fully curable if proper treatment is taken, yet HIV and TB continue to spread. Why is it so? It's because poverty, exclusion, and inequalities continue to fuel both TB and HIV. And we have seen many of inequalities that facilitated the spread of AIDS epidemic. They are discrimination, gender and income inequalities, violence and harassment. They are getting worse now in times of COVID. And therefore, this is extremely relevant topic that we are discussing today. We have seen COVID-19 has brought these inequalities to the forefront and exposed the fragility of gains we had made. And that's why the new global AIDS strategy seeks to reduce inequalities that fuel the HIV and AIDS program. And we need to understand that only treatment will not work. And that was my first point. Now I come to the second point, which is investment in universal social health protection is key. Extending social protection coverage is extremely necessary to eliminate poverty, reduce inequality, and facilitate access to healthcare, promote gender equality, in broadly speaking, basically to achieve well-being for all. And that is why we all remember that SDGs, the Sustainable Development Goals, have a very clear target 3.3, related to social protection, and which is to be achieved by all member states, and everyone is committed to that. We should be mindful of the principle of SDGs, which is leaving no one behind. That should drive our efforts. This means what? This means we shouldn't be satisfied with the percentage and numbers of our coverage, but we should look deeper into why some of the populations are not able to access services, and keep a focus on those who are furthest behind. My third point is social protection is not yet a universal reality. We know there are gaps. According to the latest ILO report on world social protection, only half of the world's population is effectively covered by at least one social protection cash benefit. But more than that, 4 billion people stay unprotected. There are major differences in different regions, and there's a huge problem with coverage in terms of population groups who are being left behind. So what do we see here? The social protection is actually failing groups who are in situation of vulnerability, and these are the people who need it most. So people living with HIV who are at the risk of acquiring HIV, or those who have TB, young people, women and girls, people with disabilities, refugees, migrant workers, asylum seekers, people who have a different sexual orientation, and many more. They are actually disproportionately affected by the gaps that we see in the coverage. They need it most, and yet they don't access it because of a number of reasons. And therefore, in today's discussion, we do need to really understand what could be done to enhance the coverage of these groups. Next, I would say that, in some countries, we do see that groups are covered, but inclusion in social protection policies and programs do not mean that they have access. These are two different things. Of course, we should make sure that those who are excluded should be included, but we should also go a step further and try to see that everyone has access. And therefore, the evidence that we have in front of us from HIV, we find that there are gaps related to lack of knowledge. People sometimes are not even aware of existing programs. There's a stigma and discrimination that people face in accessing services, and they also face barriers in the procedures, because procedures of accessing programs are often difficult from the perspective of people living with HIV, from key populations, and from other groups. And therefore, it is important that social protection institutions, and I'm happy that we have a panelist from Kenya in this call today who will be speaking. So it's very important that social protection institutions partner with community-based organizations, organizations of people living with HIV, particularly to identify the barriers that they face and then try to enhance the reach of the programs. Many times it calls for small actions. And I can share very quickly an example from India, where when we were mapping existing social protection programs, we mapped a number of schemes, and we found that people living with HIV were not able to access schemes because there was a scheme called widow pension, but that was available for women who were 35 years and older, but HIV women who were widows were much younger. So we brought it to the knowledge of government, and they changed that clause. They removed the clause of age for people living with HIV, and therefore women were able to get that access. And the last point I would make is, of course, we have these challenges, but there's a hope. And this hope has been actually shown by the way protection measures have been taken up in times of COVID. We see some very good measures coming up, and we see that there is a possibility that we can do much more than what we have been doing. So the publication that we are launching today is important because it captures a number of concrete examples and institutional practices that were adopted by social protection institutions with a view to being more inclusive of people who have HIV and TB. I'm sure these practices will inspire and encourage more institutions and practitioners to come forward, look into that, and try to go deeper into taking practical actions that they could do to enhance their coverage. I look forward to a very interesting discussion, and I'm sure we will go back with this webinar with some concrete ideas. Thank you very much. With these words, I would now invite our colleague Lou Tessier. She's the Health Protection Specialist in the ILO's Department of Social Protection to make a brief presentation on this publication. So over to you, Lou.
Thanks a lot, Asfa, and thanks to the organizers. I will try to be brief and just give a glimpse of the content of the publication to give as much time as possible for our distinguished panelists to discuss. So let me just share my screen with you. Does that work? Can you see my presentation?
Yes, we can see. Please.
Yes, we can. Do you see the presentation or?
We don't see the slideshow. We see the notes.
Yes, better.
Yeah, now it works. Go ahead.
Now it works. Okay, great. All right. So just to give you a brief introduction of the content of the presentation of the publication itself. So why do HIV and TB responses matter when we talk about universal social protection and universal social protection systems? First, it's important to highlight that while HIV and TB responses have historically focused on vertical disease control programs, now we see that increasingly social protection systems are called upon because the financing of those programs is becoming a lot more based on domestic funding, in which, of course, social protection systems have a role to play. The second point is also that key vulnerable populations that are affected by HIV and TB are usually amongst the hardest to reach and tend to be disproportionately represented within existing social protection coverage gaps. So if you see the figure on the right-hand side of the slide, you'll see this is an extract from the latest World Social Protection Report that illustrates what those coverage gaps are globally. And while we don't have a disaggregation that would allow us to specifically say where the people who are affected by HIV and TB or households that are affected by HIV and TB stand, we know from the different evidence that's been gathered over the past decades that they tend to be very much within the uncovered groups. And this represents a key obstacle to reach the universality of protection in line with SDGs 1.3 and 3.8. And then lastly, as the COVID-19 crisis has shown, social protection systems have played a pivotal role in responding to communicable disease outbreak, and in particular in protecting people's health, jobs, and incomes. So just a quick reminder on social protection within the Agenda 2030 and the interconnectedness of the SDGs. So of course, in particular, the social protection systems contribute to SDGs 1.3 and 3.8. 1.3 looks specifically at building social protection floors for all securing income security, while SDG 3.8 looks specifically at achieving universal health coverage and effective access without hardship to health services that are comprehensive and adequate. Of course, within this stream, actually, social protection systems contribute to the larger picture of the SDG framework, and in particular, SDG targets 2, 5, 8 on decent work, 10, and 16. Just to have a look on how income security plays out throughout a life cycle approach, which is the approach that is adopted by the SDG framework and by the ILO Social Protection 4 recommendation. Here you can see that the idea is that social protection is meant to be universal, and it is meant to translate into a life cycle approach whereby for every contingency or shock that one can confront in their lifetime, they are covered, and there is a solidarity-based mechanism to protect them against the shocks in question. Just a reminder of the few key principles of ILO's normative framework on social protection, and the fact that it does provide for universal effective access to accessible, available, acceptable, and good quality healthcare without hardship, but also income security for all, including for sickness and maternity. While this is true and the normative framework has been in place for some decades and has been reinforced and reaffirmed with time, including during our last International Labour Conference discussion in 2021, the reality is that people living with HIV and TB face, multiple discriminations and barriers in accessing services. And here you have a glimpse of some of those barriers. This is also why we're saying here that inclusiveness is not an option for social protection systems if they want to effectively become universal. So now, why does social protection matter to HIV and TB responses? And here it's worth mentioning that actually social protection is identified very clearly in the global responses to both HIV and TB. One is that households that are affected by those diseases see their income security affected by costs that should actually be covered by national social protection system through different types of benefits. So you have medical costs, prevention, consultation, treatments, but also non-medical costs, nutrition, transport, and income loss, incapacity to work because of sickness or time seeking care, or even job loss for some people. And that connects very strongly with the fact that if there aren't good anti-discrimination policies in place in the workplace, job loss is also a lot more common than it should be. In turn, the absence of social protection reinforces factors that then make populations more vulnerable to the spread of those diseases, in particular poverty, social exclusion, and lack of access to health and social care. And so what we're saying here is also that then this creates further a vicious cycle that is keeping us away from reaching SDG target 3.3. So what is the report recommending? Well, it recommends, it makes recommendations along, I would say, three main points. One is the need to improve the responsiveness of social protection systems. And this means that we need to have an increased mobilization of domestic resources and progressive horizontal integration of HIV and TB program into national systems. and they're necessary to sustain national responses over time. So it means that social protection systems need to also take their responsibilities in this respect. The second point is that there is a need to adjust some features of social protection schemes to improve their responsiveness to the special needs of people living with HIV and or TB or their household. And this is, as Afsar was giving the example of India, this is a typical example of specific features of social protection schemes that were there that actually don't work for the specific cases of households that have been affected by those diseases and that need adaptation and change. And then there is the effective coordination across different social protection schemes to ensure the effective combination of care and income support. Because as we've seen in the previous slide, this combination is likely to be needed for those households. The second point is to improve inclusiveness. So people who are most at risk and people living with HIV and TB are often hard to reach, and key and vulnerable populations often suffer from stigma and marginalization, as was shown in previous slides. Therefore, ensuring that those people and their family are included in existing social protection schemes and extending the coverage of these schemes is not only necessary, but also central to the agenda for the sustainable development goals and leaving no one behind. And then the third point is really enhancing participation and partnerships. So here there are two important aspects for social protection systems. One is their governance structure and how one ensures that key and vulnerable populations also have a voice within those governance structures. And then the second point is really linkages with community-based organizations and health services in workplaces that are needed to expand the reach of social protection coverage, but also more than anything to act on referral and information and awareness raising mechanism to overcome the administrative burden of accessing those services for many people. So what are the next steps for the ILO? Well, I think we can mention that we're supporting the WHO Global Tuberculosis Partnerships effort to develop social protection guidelines for national TB programs. And Ernesto, who's in the panel today, can certainly tell us more about this initiative. That we are also conducting research between the social protection team and the occupational health services team to look at financing and referral mechanisms between social health protection systems and health services in the workplace to ensure that people are properly referred and that they can overcome those administrative barriers that we discussed. And then through the IATT on social protection, the ILO, WFP, and UNH Secretariat, with support from UNICEF, World Bank, UNDP, UNHCR, will continue to focus on three key areas on social protection. One is generating evidence. Two is supporting countries to identify and remove barriers, and also documenting good practices. And with this, we have put forward a series of key resources here for you. The PowerPoint will be accessible for all participants. And of course, before looking at all of those resources, we encourage you to read the publication itself. I'm now going to thank you so much for your attention and leave the floor to our distinguished panelists that I personally take the opportunity to thank for having been with us today. Thank you.
Thank you very much to Lou for this very insightful presentation. Thank you so much. And thanks to Afsa also for delivering the opening remarks. I think at the heart of what we are saying is people living with HIV and people with TB, for many reasons we have mentioned, are not able to adequately access social protection services. And this panel discussion is going to delve into some of the country experiences with a very knowledgeable panel. And I'll start with, I think, David, I'll start with you. So David Chipanta is the senior advisor working in the area of social protection with UNAIDS. David has been leading the work on UNAIDS in this area for several years and has considerable experience in this area. David, my first question to you is, based on your experience, based on all the work you've been doing in supporting countries to do HIV assessments, what is your initial reaction to this presentation?
Thank you very much, Kofi. I think this is really excellent. I think my first reaction, our first reaction is that this report is really timely, and both Lou and Afsa, gave us a really strong background why this is timely. But maybe just to add to what both eloquently said is that we are looking at 37.7 million people that are living with HIV as at of the end of 2020. And of these, 24.8 million were receiving treatment and they were HIV virally suppressed, meaning that they are in good health and they can go back to work and they are not able to transmit. But unfortunately, there were 12.9 million people living with HIV who were not virally suppressed. At the same time, we had 1.5 million people that were newly infected. So that is the magnitude of the issue that we are dealing with. And Lou and Afsa mentioned that there are a lot of services around, but inequalities are preventing people from accessing these services. And at the same time, social protection does help. And this has been very well explained, but it has also been emphasized in our 2021 political declaration, which was signed by member states. In that declaration, the member states really pushed forward. They raised the bar that we must ensure that 95% of people living with HIV know their HIV status, and that 95% of people living with HIV who know their HIV status access treatment, and the same number are also virally suppressed. The same meeting, which is led by UNAIDS, also endorsed the new target on social protection, which is to ensure that 45% of people living with HIV, and those at risk of or affected by HIV, have access to social protection benefits. So these reports really speaks to both the burden of the HIV infection, but also the political commitment that is there to make sure that we end HIV. So it's really, really timely, Kofi, and really excellent and very well needed. It will help us really with the path forward.
Thank you very much, David, and thank you for talking about the political support to address this issue. I'll now come to Dasha Patel, an activist with the National Coalition of People Living with HIV in India, a human rights advocate who has supported the development of the capacity of people living with HIV community-based organizations, and who has worked very actively in human rights, care, support, and treatment. Dasha, you're welcome. My question to you is also, just like David, I want you to react to what you've heard, but from the perspective of communities and people living with HIV.
Thank you, Kofi. And this is really very excellent report. And when I seen presentation and this report, lots of stories which is related to social protection, accessibility and challenges, and what we are doing in an advocacy way in a state and in a country, that was run through in front of me in my eyes. And one thing, some correlation I also thought in my mind in report, which I thought I feel that people live for TB and who are living with HIV, they need to visit very frequently to the ART center to access their medicine. And even in some of the period, like during the stock out or like COVID situation, that was a very big hurdle for people to access the healthcare services. So in that time, uh, like uh, like the support, social protection will if integrate in for every HIV positive and TB people, it would be more effective to ensure the adherence level of community member. This is how it is. It sustain the services of healthcare through the social protection scheme. And some of the area I also seen in the report, like social protection will help to improve the treatment care support for community members. So yes, Coffee, this is a very interesting things I found.
Thank you, Dasha, and thank you for reminding us about the role of social protection, particularly during COVID. And before I come to Richard, I just want to remind the audience to please put your questions in the Q&A function below. We want to get as many questions from you as possible, so please do not forget to give us any questions that may come into your mind. So Richard Obiga is the Senior Program Officer with the National Social Protection Secretariat of the Ministry of Labor and Social Protection in Kenya. And Kenya, I must say, has been doing some very good work in terms of removing some of the barriers for people living with HIV and people with TB to access services. Richard, what is your impression and what experience do you bring from Kenya to complement or otherwise what you have just heard in the presentation?
Thank you so much, Kofi, for that, and my colleagues, the panelists, and even Louis, who has brought in the report. First of all, I must say this is a very good report and a timely report. And I just picked from your last statement before you gave me the chance in terms of social protection and people living or at risk of HIV vis-a-vis now the advent of COVID. And this has clearly brought forth the importance of social protection in ensuring inclusivity and in ensuring responses in shock situation. Practically in the country, we're one of those countries, just like any other country, where we realize the adverse effects of the pandemic in terms of the lockdown. And I know it will come out later as we discuss how most of the patients and the clients were not able to access. So the treatments, the diets, the type of nutrition that was necessary for maintaining their health. So indeed, for sure, this exposes the urgent need to expand and develop very sensitive social protection mechanisms and systems that are keen to the plight and the needs of people living with HIV or at risk, and also TB. So as a country, I can say, yes, I'll be giving further examples, but I must say this is one country where we've made significant gains to ensure that persons living with HIV and also TB are best addressed, reduce on stigma, exclusion, and I really like the focus of the research in terms of the institutional practices, because unless these are appropriately institutionalized, then they cannot be sustainable and they cannot be comprehensive. So as a country, I'll be maybe in the second part of my response, I'll be giving practical examples of how as a country we have put right institutional mechanisms and the responses that have come forth within those institutional frameworks to ensure that, persons living with or at risk of HIV and AIDS and also TB are best cushioned, and also they are able to, properly integrate and with clear referral mechanisms to be able to support, dignified living and also be able to access, productive and inclusive initiatives. Thank you, Kofi.
Thank you very much, Richard. And I like particularly what you said about the fact that some of these measures have been institutionalized, because without institutionalizing these measures, they would appear ad hoc. I think we will come back to you on that. The last but not the least panelist is Ernesto Haramillo, who is a medical doctor and currently the lead for human rights, social protection, and TB-associated disability in the WHO Global Tuberculosis Program. I'm sure you all know Ernesto. He's quite a familiar face in the work of TB and social protection. So Ernesto, I would want you to respond like all colleagues have done, the panelists have done in the first round, to your impressions about what were your initial thoughts as you listened to the presentation.
Thank you, Kofi, and thank you for all of you for putting together this webinar. I concur with my colleagues. It was very timely, and certainly we are going to take stock of the recommendations for the sake of the guidance on social protection that the Global Tuberculosis Program Department in WHO is developing and hopefully launching in the summer. I mean, it's like a broken record to say that tuberculosis, more than anything, is a social disease. However, the TB community has somehow been a victim of the success of access to tools that cure the disease for many decades. And that has resulted in stagnation of the development in the field. But this all has changed dramatically with the NTB strategy that was launched in 2015 by WHO and endorsed by member states. And that has made very clear and that social protection and action on the social determinants of TB is not an option or a cherry on top of the cake of the biomedical interventions, but a must. However, converting that kind of political statement and generic principle into reality in the field, into really game-changing intervention, it's something that is proving to be more complex and more challenging than anybody could have expected. Somehow, it could be expected in the way that health systems are more comfortable and familiar to do what they are used to do, collect sputum samples and manage the delivery of pills and treatment for people affected with TB. While work on social protection means to engage with actors beyond the health sector and to engage in a type of interventions and negotiations that are not usually the area where healthcare workers and Ministry of Health itself feels more comfortable. But there is in the set of recommendations that Lou has presented is the call for more active engagement of civil society in the NTB strategy and within the work that the Stop TB Partnership does and WHO does and many stakeholders do. Civil society is the key actor, right? And we fully concur with the statement, nothing about us without us. However, it has been kind of disappointing over the years that the demand from civil society has focused on the biomedical interventions. Strong demands for more diagnostics, for more medicines, for vaccines, but lukewarm demand for social protection, for action on the social determinants. And here is a good opportunity to invite civil society, community organizations that are involved in the response to TB to be more vocal and more proactive in demanding from WHO, from member states, from all other stakeholders, particularly donors, to step in and fill the huge gap we have in front of us when it comes to provide social protection to the people affected by TB. The evidence is out there. The evidence is clear and conclusive that social protection does make a difference in the lives of people, but also in terms of the incidence and mortality of tuberculosis. So I just want to confirm that the Department of Tuberculosis here in WHO is fully committed and is making of the social protection one of the fundamental human rights that we need to take stock in order to really make a dent in the current epidemic of tuberculosis. It has been a pleasure to work with ILO and with many other UN agencies and other stakeholders in moving forward this agenda. Thank you, Kofi. Over to you.
Thank you very much, Ernesto, for your quite provocative but very interesting comments. And I want to move to Dagza. I was going to stay with you, but you raised an issue about civil society, which made me think I must go to Dagza immediately as the voice of civil society here to hear whether she agrees with you and what is the experience in India based on what you said. But specifically, Dagza, your second question is, people living with HIV and people with TB face many barriers in the uptake of services, like we have all said. In your opinion, what are the three most essential barriers social protection practitioners must know? So you can react briefly to Ernesto and then respond to this question. Over.
This question is seriously, it's funny for personally to me, because the barrier, if I will say, for social protection, it is a two-way to access, and second way is about who are the advocate for making influence in the policy and designing of any government rules, regulation, and many things, and to make sure that social protection scheme will reach to last person who is really required that support. So let me start with your specific question. Like in COVID, first I will share my experience. That was a totally, the services was hang up, and like access of health services, testing, screening, diagnosis, all things were stopped due to the COVID and lockdown. And if I will say about social protection, it was a very, very big challenge. But that was a time when exact the people was in a need to they required the social protection facility, because they don't had an income, and many things already mentioned in a report also. But they are not willing to make any renewal process, paperwork, and lot of criteria. Even in a country in India, many COVID specific social protection scheme was introduced by government of India. But it is also one of the, again, challenging, because the death certificate a person has to submit, and that was not specified the death reason. Sorry, my so it is not reflect in a death certificate about reason is a COVID specific. So it was again challenging to how to explain individual at the level of submission to access that COVID specific social protection scheme. And in general, like a state, national, and if we will say like a specific to department officer, there is a difference of mindset and guideline, and there is a on perception related to the community member. So it is one of the major barrier, and we are not counting as a big vote bank for political level. So if any small changes or any like in a political agenda, the social protection for TB or HIV, it is not in a priority. So that is one of the another barrier to make any changes. I just giving my last line that one social protection scheme, we worked with the state government minister, and we took that on ground in 2009. And it was a required and it was high demand. We found it needs to be revised. Since 2017, I'm continuing fighting with the government, and I have like hope now for because our state health minister is very sensitive now, and she given certain commitment to make these changes. So our resources, our energy is also very much limited, and the donors require some immediate result. But advocacy is not like one day business or one day job. It is a long, long way. It needs to be. We need to follow that. This is the experience from India, or even in other country also. I hope it is a similar. And for TB, I want to say only one point. It is a very medicalized. So human touch is required. So if I have stomach pain and I will shout, it make different. Instead of another person will say that how much I have stomach pain. so
Thank you. Yeah, thank you so much, Dasha. You raised a lot of points. I hope Lou, the presenter, is listening, because we will give you a chance to react and to share some ideas on some of these issues that are being raised. Richard, I'll come back to you. Earlier on, you spoke about some institutional practices that are extremely important in making sure we cement some of the measures we are speaking about. Can you give us the Kenyan example, 2 or 3 things you've done to really improve access for the populations we are talking about? Over.
Thank you so much, Kofi, for that question. And I think these are very critical points that even my colleagues have alluded to. But allow me to say that as a country that also has, among it globally, ranking very high in terms of HIV incidence and even TB, because we have around 1.4 million people with HIV, almost number 4 globally. You know, we have been forced to make quite some significant adjustments in terms of our responses. So just to be very straight to the point is, I would want to see this in quite a number of areas, which I also appreciate that the report as well captured in terms of the structures and the institutions that you'd want to bring forth. So in terms of social assistance, because for example, focusing on social protection, I must say the initial program, the first program that we had as a country, the cash transfer to orphans and vulnerable children, which started way back in 2004, was actually started as an issue that arose from the high incidence of HIV and AIDS. The orphanhood, the high orphanhood that was being realized from that particular bracket. And those started by partners, but has grown and has finally been taken up by the government and is now fully government supported and has further expanded. But because of the lessons from that, owing to such vulnerabilities, now we are even advancing that further to put a universal child benefit, so that at least we have that level. And of course, looking at the incidences of even HIV amongst that active population is a serious step. I know we are still to get active legislations around our cash transfers, but that withstanding, I must appreciate that as a country, we are also championing the universal health coverage as a serious key government agenda under which we'd want to ensure. And in our current project that we are running in the State Department for Social Protection, we want to prioritize, some of these vulnerable groups. We have a Kenya Social Economic Inclusion project that we're running that would want to see how then do we ensure coverage to these most vulnerable and prioritizing especially that. Allow me, Kofi, to say that in terms of establishing data, because data is everything. Currently, we are building a database for the poor and vulnerable. And one of the key instruments we are using is sensitive. We have a question that is well designed to be able to capture persons with living with HIV and AIDS and TB. And I can say that we undertook this in the initial counties in Kenya or regions with the NASCOP, the control body, an AIDS control body that is in Kenya. But that withstanding, Kofi, I must say, I know you've read this and a number of countries have did that. Kenya has clear legislations, and I don't want to mention the constitution, but I would want to point out the tribunal, because I think Kenya is the only country in the world that has an AIDS tribunal, which is able to escalate and take issues of HIV and AIDS, so that issues of stigma, exclusion, and discrimination have a clear, legal provision, just even beyond. So the act has effectively given space to the establishment of the tribunal, which is now very active. And I think this is something that is a big step to the country, and I think a lesson to quite a number of us. And finally, I must say, in terms of just institutionalizing, there is an issue that was raised by one of our colleagues in terms of continuous advocacy and sensitization. And I must say that the Central Organization of Trade Unions, COTU, together with NHIF, the leading health protection provider in the country, have continued in well-structured sensitization and advocacy on the rights of the workers, and also just seeing into innovative ways of expanding social protection, especially to the informal, which the sector, the report has clearly articulated, and where there is a serious gap. And that is where we'd also want to see how then can we continue to entrench social protection programs that would facilitate not only national government responses, but also you can see a lot of leveraging on community-based structures like the community-based health committees that are a long way in providing that gap. So I think as a country, this is one thing that I can really point out. And of course, even currently under the program we are doing in social protection, we want to see into how can we provide other complementary programs that would see into enhancing the productive capacities of persons living with or at risk of HIV and including TB. So just apart from the cash transfer programs, we'd want to see also that we have more inclusive and productive schemes that would help persons living with and at risk of HIV also be able to participate effectively into the productive chain.
Thank you so much, Richard. Yeah, so much food for thought in there, and thanks for mentioning the very well documented HIV tribunal story, which is one area where Kenya has shown leadership globally. I'll come back to Ernesto. Ernesto, you have been playing a key role in the development of TB guidelines for NTB programs. How have these guidelines addressed the specific and peculiar needs of people with TB? So here Ernesto, I want you to focus on your guidelines, the work you've done around it, and just tease out some critical lessons that you want us to take home today.
Yeah, well, thank you, Kofi. Well, we because of the reasons I presented before and the emphasis on a biomedical response to TB, there has been too much emphasis on examining first facts and not only values, right? And hence, although social protection and solidarity and all the elements that are within the ethics framework of the NTB strategy are very well respected and accepted, when it comes to implementation, people want to see what to do and how to do it. Then the focus on the guidelines have been always looking at what the data is telling us about what makes a difference. And when it comes to social protection, no surprise, the evidence was there showing that when people who are vulnerable, who have a disease like TB, who are marginalized, receive health education, receive patient counseling, receive psychological support, and receive social assistance, that has a tremendous impact on the treatment outcomes, which is the kind of holy grail by all TB programs, to ensure that everybody is cured. So drawing on that evidence, it has been possible to escalate the need to make social protection, as I mentioned before, not an option, not a way to look nice and behave nicely with poor people. No, it's a must. It's a human right. It has to be protected. It's something that people are entitled to, particularly because of the vulnerability they are living with, they are facing. So it's the way to address the root cause of tuberculosis, to address the social determinants. And because it's a human right, so we are ensuring that through all our guidelines, we are keeping an eye to ensure that social protection opportunities are not missed. That through the guidelines and through the supported countries, we ensure that when it comes to diagnosis, to treatment, but also to other elements like the development of research, we can focus on what is needed for strengthening the social protection component. Over to you.
Thank you so much, Ernesto. Thank you so much. So I'll come back to David. That's where I started. So and then where I started, and then I'll go back to the audience for some questions. David, with all your experience, what would you say have been the 3 critical social protection barriers that people living with HIV and TB have faced? I mean, you probably speak more from the HIV perspective, but I think you can speak for both. And how have these been addressed in your experience and your knowledge? After this, I'll come to Lou.
No, thank you so much, Kofi. Ernesto, Dasan, and Richard mentioned some of the barriers. Just to say that as UNAIDS, together with ILO, WFP, UNICEF, and others, we have conducted HIV and social protection assessments in 18 countries. So we use these two, which is in English and French. And through these assessments, we try to see how connected HIV and social protection programs are in the country. And out of that, we get recommendations of how to better include people living with HIV. And what the 3 speakers have said have been really some of the key things that have been coming from these assessments. I think the first is probably what Winnie, the UNAIDS Executive Director, often alludes to, that inequalities do kill, and that we should not make the mistakes of the HIV epidemic. I think Richard mentioned earlier on that when the HIV epidemic started, we gave some people some services, and we didn't give some people some services. Some of us benefited because we were connected and we were in these groups. Others did not benefit. So I think one of the issues people living with HIV have been telling us is that we have to make these programs universal. I think Lou mentioned that. Because some of the people may be vulnerable, but they may not fit, those categories that you mentioned. They may be vulnerable, but they will not fit. As a result, they will lose. They'll lose out. So one key thing is let's make these things vulnerable so that everyone really is able to access it according to their needs. So I think that's the first one. And I think this is really possible. In Cambodia, we had that example in the report showing that over 27,000 people living with HIV are included in the government program. But there are new people. Through the assessments in Cambodia, we have connected about 3,000, about 3,500 more people living with HIV and their families to this program. So this is a sustainable way, because these people are not going to receive for 1 month. They are going to receive for the long time. And sometimes the programs are blind to such people. So they do need people like us to broker these services. So I think that is one example. I think the other ones, the issues around stigma and discrimination, because these programs are often, they are discretionary in terms of the decision on who receives and not receive. So the people that communities may not like will not receive. For example, sex workers, people may think that they are rich, but they are not, and they may not be liked so they will not access. So I think those are just two examples. Then the last one, Dacia mentioned it very well. How do we remove the conditions for people to access these programs? For example, if I don't have an ID, can't I access the programs? So I think those are three critical barriers, and I think universal social protection is the way to go, so that it doesn't depend very much on who someone knows. Yeah.
Thank you, David. Indeed, universal social protection is the way to go, as long as it is truly universal and is able to reach the hardest to reach. I promised to take some questions from the audience, so I have a few here, and I'll start with Lou, who has been silent after her presentation. Lou, there'll be two questions for you, quick ones. The first one is, you have heard a reaction from the panelists to your presentation. Are there any comments you would like to make in that regard? But the second specific one is that, are there plans to develop social protection guidelines for national HIV programs as well? So are there any plans to develop SP guidelines for national HIV programs as well? I think, Lou, you would start. If any other panelist wants to take this question too, you could. Then I'll go to a few other questions. Over to you, Lou.
All right, thank you so much, Kofi. Well, I mean, I think that I would like to thank all the panelists, because it's been very rich discussion. I mean, maybe if I can pick up on David's point, just to say that, as David has mentioned, there are HIV and social protection assessments that have been done, that continue to be done. Those contain a wealth of knowledge and the very details of the barriers of access. And I think that those need to be the starting point for institutional reflection from the social protection system perspective on how to overcome those barriers. And I would like to say two important things. I mean, the first is that it will be beneficial for the social protection system itself, because as it's been mentioned also in the questions in the chat, the communication on rights, for example, is a very important issue. It's a very important issue for those populations that are at risk or affected by HIV and TB, but surely it is generally for all very vulnerable groups. So what, it made me think I was at the launch of the global TB report 3 years back, and there was a representative of civil society that was there, and that was very rightly pointing out something that stuck with me, that, what works for the most vulnerable will work for the rest. So this should be the starting point in designing administrative procedures and practices that can be easily accessed on a universal basis. So the second point is that, there are some institutional barriers for social protection institutions themselves. So for example, what we're also seeing in the report, and that I believe deserves a lot more research and probably action research is that when we look at the potential and the need for doing partnerships with CSOs, some countries have not the best enabling legal framework for social protection institutions to be able to do partnership and contracting with CSOs and CBOs. And this is something that would really deserve being looked at to also overcome those barriers. And then, on your question on plans to develop social protection guidelines for national HIV programs, well, I think, Kofi, this is a great idea. So, I mean, it's not really for me to say if there is a plan, but if there is interest, I would think that this is indeed a very interesting idea.
Your last question, I'm sure you knew I like it. David, I'll come to you, because there's the specific question on are there plans to develop social protection guidelines for national HIV programs? I'll come to you, after which I have a general question for all the panelists. But David, over to you first for the HIV specific question.
Excuse me. Thank you, Kofi. I think there are many guidelines out there. I'm sure if we ask ILO, there will be some. We do have the HIV and social protection assessment too, and a number of countries have used it. It's all modified, and there are many tools. If you go to the UNAIDS website, check that we have several tools. Are there plans to do more? I think we can still do more. I think there is a sufficient that countries can use to really to really do what they would like. So I think if a country or if a gap is identified, obviously, I think we could look, but at the same time, the wealth of tools that are there, I think let's take advantage of them. For example, the tool has been translated in Spanish, in Russian, in Portuguese. So I think there's really there's a wealth, I think, as Lou mentioned, of tools around. Yeah.
Us that there's a wealth of resource we can already tap into. Now, there's this question for all panelists or for any panelists. What can external donors concretely do when it comes to social protection in the context of HIV and TB? What can external donors concretely do when it comes to social protection in the context of HIV and TB? I think I'll go through. So maybe I'll start with Ernesto. Any comments? Then I come to Richard, and then I come to Dasha.
Well, thank you, Kofi. No doubt that they can do far more than what they have done so far. There are plenty of opportunities there for, the donors have usually a heavy hand. They assign funds to implementers and to agencies like us with some specific request. But it has been exceptional that we receive some specific proposals to leverage on social protection. There are, at least in TB and like HIV, there are huge gaps when it comes to tools, when it comes to demonstration sites, when it comes to a robust monitoring and evaluation framework. So there are an awful lot of things to do. Just to give you an example, I'm the only person that is devoted to social protection in the department, and this on top of many other things. So it's going to be not easy to provide the support that member states are in need of when we are not well equipped to implement what we already know what has to be done. Donors have to be ready to step in and also to lobby and secure that a major donor, the Global Fund, for example, be more proactive, more aggressive in ensuring that social protection is part of the solution and not a single ancillary alternative intervention to provide. Over to you, Kofi. You are muted.
I'm sorry. Thank you very much. Yeah, Ernesto, I think I'd come over to Richard. Richard, do I need to repeat the question, or is it clear with you?
No, it's clear, Kofi. It's clear, and I can't agree more with my colleague. But let me pull out differently that one of the areas, and it came out very clear in David's comment, promoting inclusive schemes. Because as long as we continue to do targeted programs, then exclusion of our, especially the key populations and people living with HIV and AIDS will continue to exist. But as more as we can embrace, and this is where they can play the double role, not only of advocacy and also seeing into how governments should take up this and promote the rights-based approach to social protection, but also the necessary financing that goes into this. Then number two, I can say that you can see the shift that social protection is taking in terms of promoting more sustainable and more comprehensive schemes, and that would go for the integrated approach. And some of these we know are fairly expensive for some of the emerging economies. So in terms of building more comprehensive, integrated schemes that would answer to the multidimensional demands of people living with or at risk of HIV and TB, this is one space that I can see the donors need to play a very critical role. And then finally, just like my colleague has said, it would be difficult to champion and advance some of these if we do not have robust systems. And he has spoken to some of the M&E and the tools, but I would want to say, building comprehensive databases that can be easily linked to other services and be able to, champion and advance, the whole social protection agenda. And just to give a very good example, what we are doing in the country now, ensuring that we have a robust database that anybody who would want to do social protection interventions, even for these specific target groups, can easily come and cut on those costs of having to go and collect that data. So, Kofi, that would be my 3 quick takes for our partners in terms of what they can support these countries and our countries be able to do. Thank you. Over to you.
Thank you very much. Thank you very much, Richard. Now I come to Dasha, the same question. I don't know if I should go over it again. Let me just refresh your mind. It says, what can external donors concretely do when it comes to social protection in the context of HIV and TB? Dasha, over to you.
Yes, Kofi. Already I mentioned when in earlier. I think in external donor, we as a community network and community members, we require. I agree with Richard what he already mentioned about database information in any organization. It's very helpful to take forward for any service upscale or any changes. But also, it's very much important to build a capacity of institution or a CBO network community for social protection advocacy and access of services. Until unless if they are not capable, they can't make any real situation, because like in India, there is a several guideline. Even MOU was signed by National AIDS Control Organization with a different line department. But there is a lack of coordination and follow-up for any take forward at the state level. Like donors should also fund for data collection from PLHIV or TB specific coverage and building their capacity, what I already mentioned, for social protection in institution. Otherwise, to access any social protection scheme, it is like we become as a file or paper to who needs to move table to table or office to office. Over.
You have a specific question and directed to you here. It says, I find the arguments convincing. I just wonder how practical those measures are in countries where the needs are so large. Also in other sectors, elderly, disability children, and capacities and resources are so limited. And this question should go to especially Ernesto.
I think that a clear example of the fallacy behind the limited resources is the response to COVID. You have seen how many millions have been flowing to develop vaccines, to develop a lot of intervention that certainly might be insufficient in terms of, might not be commensurate with the need, but are 100-fold higher than what anybody could have expected. So the resources is not the problem, it's the lack of political will to mobilize the resources where the need is. And for that is where we need to harmonize the demand from civil society, the commitment from donors, and the technical competence and capacity of agencies like WHO to provide a response where the need is. Resources is a way to distract the attention. Limited resources is argue, oh, we don't have enough for this, we don't have enough for that, you are asking for too much. We need to ask for what the people are in need of. And with the political will in place, it's always possible. Every country have a central bank that, if there is political will, can even print money and handle the macroeconomic implications of that. We are talking here about human rights. We are talking about the needs of the most vulnerable populations. There is no excuse for not moving forward in a more coherent, progressive manner. There are many other investments that are being done with less impact and for problems that are artificially created. Here we are talking about the real problems that are preventing countries to make progress. Over.
Wow, Ernesto, that was quite some response. Thank you so much. I mean, thank you so much. A lot of food for thought there. The resources are not the issue, but the political will is the issue. Thank you so much. Before I come to the closing remarks, I think it is just fair I give Anna Catalina, no, not Anna Lou, the chance to have two minutes. If there are any last words she wants to have, I think this is the chance for it.
Thank you, Kofi. I mean, I think that most of the panelists and actually also the participants in the chat have said it all. But I think that one thing that we also need to put in perspective, and I think when we think now about recovery from the COVID-19 induced economic crisis, we need to think about long-term investments in social protection systems, and the fact that, if you see, as we were saying, I mean, the more national social protection systems have coverage gaps, and the more we apply narrowly targeted programs, the more that the most vulnerable will have a chance to be left behind. So this case to invest in social protection in a way that fosters universal coverage is very important. And if there is one takeaway message, I think that can also orient some of the efforts made by the donor community. Thank you.
At this juncture, I can say thank you to Afsa, to Lou, to David, to Dasha, to Richard, and to Ernesto for enriching this discussion with your knowledge. There's a quote I saw somewhere, and I tweaked it a bit, and I want to leave you with it. It says, "We cannot change the mistakes we made in the past, but we can decide not to repeat those mistakes going forward." So there's a lot we have learned today about the past and why and how we left populations behind, and more importantly, what we can do going forward. I would now hand over to my colleague, Anna Catalina, who is a specialist with occupational safety and health within the ILO, to deliver the closing remarks. Over to you, Anna.
Thank you very much, Kofi. And I would like to thank all the participants today for joining us in the launch of this publication. I've seen that we have participants from all over the world, which is a great satisfaction. This publication is a result of a joint effort by different ILO departments and colleagues. Lou Tessier and Sven Engels, who coordinated the publication in collaboration with Kofi, Amek Dusi and Olga Gomez and myself. More broadly, I also want to thank and to congratulate the external collaborators, Felice Baker and Roman Koki, as well as the colleagues who collaborated to the study and to its launch today, in particular to Ian Orton and Sayer Mohammed Afsar. Our gratitude extends to the socialprotection.org platform for hosting this webinar. Thank you very much, Nina Brunali and your team, for helping us to navigate through the challenges of the technology. Finally, I would like to thank our distinguished panelists who have agreed to come today and bring their important perspectives to this debate. Looking forward, we believe it would be important to mobilize partnerships around the priority areas of work we identify today to make universal social protection a reality that works for people living with, at risk, or affected by HIV and TB. With this in mind, the study highlighted 4 key aspects that should have our attention and require further evidence generation. The first one is the limited information available on existing linkages between occupational health services and social protection systems. Similarly, evidence on the necessary conditions and administrative arrangements for social protection institutions to delegate some prevention and referral functions to NGOs and civil society organizations remains anecdotal. Global financing mechanisms have traditionally put an important emphasis on funding these types of organizations. But as countries are transitioning out of social global financing mechanism and absorb more of the cost related to prevention, diagnosis, and treatment, it is important that mechanisms to partner with these organizations that are closest to vulnerable populations continue to be explored. Secondly, very few studies focused on documenting effective practices to improve access to social protection from an institutional perspective. Most of the literature we have reviewed during the study provides evidence on barriers to access health services, but there is little guidance on best practices for social protection institutions to ensure effective outreach, affiliation, financing of services for vulnerable and key population confronted with such barrier. Third, the statistics on social protection coverage of key and vulnerable populations are limited. This makes it difficult to judge the scale of inclusiveness of existing social protection schemes. And fourth, to become truly inclusive of vulnerable and key populations and responsive to their needs, social protection system will need to systematically take into account HIV and TB responses. Therefore, it would be important to mainstream HIV and TB into the tools used by social protection practitioners at the global and country levels. Further comparative research along those 4 axes across countries could identify valuable policy lessons and social protection and pandemics such as the one we are living now. Dear participants, I hope this session has been as inspiring for you as it was for me, and we look forward to continuing the good collaboration. I wish you a very nice rest of the day. Thank you very much.
Well, thank you very, very much to all our participants. Without you, we wouldn't have had this rich session. So thank you so much. And the very best for the rest of the day. Thank you and goodbye.